Hi guys, so today we're going to be doing 14.4 through 14.6. So we'll be starting today with 14.4. This is all about the respiratory volumes and capacities. So for a healthy adult, the average breathing cycle per minute would be 12 to 15 quiet breathing cycles per minute. So quiet breathing or resting breathing, remember that's the same thing. In the clinical setting, a lot of the time we will just say 12 to 20 is normal, but for the terms of your book, they deem that 12 to 15 is a normal cycle for a healthy adult. What is a breathing cycle? A breathing cycle is one inspiration followed by one expiration, and the volume of air that's inhaled and exhaled during resting and forceful breathing cycle will vary. Some of the factors that will cause this cycle to vary would be size, age, sex, or physical condition. So volumes 80% or less than average healthy range indicate some sort of pulmonary disease. How we determine this is using a tool called a spirometer. So spirometers are used to determine respiratory volumes, and what it will produce is called a spirogram. So the spirogram is the actual graph or a graphic record of air volume that's being exchanged. In this picture, you're looking at an incentive spirometer. A lot of times we use this after surgeries. It helps to keep the lungs expanded and prevents pneumonia. The patient will breathe into the device and the bar will move upward, and we'll be able to see how much volume this patient was able to take in. This would be an example of the spirogram. So again, this is a graphic record of air volume that's being exchanged. So you can see all of these different terms, which we're going to go over each one of these. So don't stress too much about it quite yet. But you can see that we have a total lung capacity would be going all the way up and down, vital capacity, inspiratory capacity, functional residual capacity, and then so on. And like I said, we will come back to this in just a few minutes. So now we're going to define some of those terms. So first is something called tidal volume. So tidal volume is the volume of air that's exchanged during a resting breathing cycle. That's key there. So this is at rest, and I would highlight this term. Know what the definition of tidal volume is. And this is usually approximately 500 milliliters for the average healthy adult. The term inspiratory reserve volume, or IRV, this is the maximum volume of air that can be forcefully inhaled after a tidal inspiration. I would also highlight this definition and know what an IRV is. This is approximately 3,000 milliliters, so it is a much greater amount of air. Then we have your expiratory reserve volume, or ERV. This is the maximum amount or volume of air that's forcefully exhaled after a tidal expiration. So the key difference from the last term here is now we're talking about expiration compared to inhalation. This is approximately 1,100 milliliters. And then lastly is your residual volume, which, as it sounds like, it's the volume of air remaining in the lungs after expelling the ERV. And again, I would highlight that definition. Know what your definition of an ERV is, as well as a RV. This would be approximately 1,200 milliliters, and it exits because of intrapleural pressure and surfactant. Again, this is what keeps the lungs expanded or partially inflated at all times. Next, we have your vital capacity, or VC. This is the maximum amount of air that can be forcefully exchanged. The equation for this would be TV plus IRV plus ERV. So this is everything put together. This would make up approximately 4,600 milliliters. So this is putting together everything together at rest, and both are forceful inspirations and expirations. Then we have the total lung capacity, or TLC. This would be your vital capacity that we just talked about, plus your residual volume. So this is everything the lungs can hold at all times, and this would approximately be 5,800 milliliters. I would highlight the definition of vital capacity. Again, coming back to this graph again, now you can really understand what this graph is talking about. Again, this would be a spirogram. So here you can see first our tidal volume, which is just the air that's exchanged during a resting breathing cycle. Then we have our inspiratory reserve volume, which is the amount of air that can be forcefully exhaled after a normal expiration or inspiration. Our expiratory reserve volume, which is how much can be exhaled after a normal expiration. Our residual volume is what's left over. Vital capacity, as you can see, is our tidal volume, IRV and ERV put together, and then total lung capacity is everything, your vital capacity and your residual volume. Now moving on to 14.5, we're going to talk more about the control of breathing. So our centers for involuntary control are located in the medulla oblongata and the pons. I would highlight those two terms. Make sure you know that this is where our involuntary control of breathing is contained. Remember that involuntary means that this cannot be controlled. So this is our times at rest, our breathing at rest that we're not thinking about, that is just happening. We then have voluntary override. That's when we breathe over our resting rhythm. So that's something we are consciously controlling. This would be controlled by the primary motor area of the cerebral cortex. And you can see here on the brain where those areas would be located in case you need a little bit of a refresher. Our respiratory rhythmicity center, this is located in the medulla oblongata and consists of two components. So the first would be your ventral respiratory group, or your VRG. Your second would be the dorsal respiratory group, or the DRG. So this is just really two different groups of neurons, and you can see them here in this picture. Up at the top you see the DRG is the green section, whereas the VRG is the blue section. So talking first about the VRG, or the ventral respiratory group, this is responsible for normal rhythmic cycle of breathing, and I would highlight that first bullet point. Here, your neurons are going to be rhythmically sending action potentials to the diaphragm and the external intercostals. Remember, these are your two muscles that are going to contract in order to have inspiration. So these are going to cause them, these neurons sending these action potentials is going to cause these two muscles to contract. So the action potentials cause the muscles to contract. Inspiration occurs for approximately 2 seconds. When the action potentials stop, the muscles relax. That causes expiration, which will occur for about 3 seconds. Again, this would be during a resting breathing cycle. Your dorsal respiratory group, this is the center for receiving and integrating input from the sensory sources. I would highlight that first bullet point. Know what your dorsal respiratory group is. Your dorsal respiratory group is going to send action potentials to the VRG in order to alter breathing as the needs of the body change. This means that we can breathe deeper or shallower, faster or slower, depending on whatever our body needs at that time and depending on whatever situation we may be in. And we're going to talk a little bit more about this later on in the chapter. Then we have another respiratory group that we haven't talked about quite yet. This is called the pontine respiratory group, or the PRG. As it sounds, this is located in the pons. This is going to receive input from the higher brain centers, and I would highlight that. I would know that this is located in the pons and that it receives input from the higher brain centers. I also would highlight this last bullet point, which says that it sends action potentials to the DRG and VRG in order to modify breathing pattern. So overall, the PRG controls the VRG and the DRG. So when it sends these action potentials, it's either going to stimulate or inhibit, depending again on whatever our body needs. So the PRG is going to have neurons like I said, either stimulate or inhibit the VRG and DRG. Depending on what the body's needs are, it will either slow up or speed up and slow down the transition from inspiration to expiration. And this will alter the rate and depth of breathing. So this also will adapt breathing to speaking, singing, exercise, sleep, and emotional responses such as crying or gasping. All right, and moving on to our last section, 14.6, we're going to talk a little bit more about other factors that will affect breathing. So before we get started on this slide, there are 5 factors that affect breathing, and I would write these down. So 1 is chemicals, 2, body temperature, 3, inflation, 4, irritants, and 5, higher brain centers. So I'll go over those 5 one more time. 1 is chemicals, 2 is body temperature, 3, inflation, 4, irritants, and 5, higher brain centers. I would be familiar with these factors and be able to pick out what is or what is not a factor that influences breathing. So starting with our first one, we're going to start with chemicals. So chemicals are the most important, the most important chemical factors in blood and cerebrospinal fluid that affect respiration is this list right here. So first is CO2 or carbon dioxide. Next is H ions or hydrogen ions. So this is the byproduct of carbon dioxide transport. So an increase in carbon dioxide concentration in the blood will cause an increase in hydrogen ions. Remember, hydrogen ions are important on the pH scale because the more hydrogen ions we have, the more acidic a solution is. So keep that in the back of your mind once we talk about pH regulation a little bit later on. And then lastly is oxygen. All 3 of these chemicals are picked up by the chemoreceptors in our blood and then will transmit them to the brain centers in order to alter our breathing. So like I said, the chemoreceptors located in the medulla oblongata will detect changes in hydrogen ions and CO2 in the cerebrospinal fluid. I would highlight that bullet point. Just make sure that you know that your chemoreceptors are specifically in the medulla oblongata. They are not located in the pons. We also have chemoreceptors in the carotid and aortic bodies, and these are going to detect changes specifically in hydrogen ions, carbon dioxide, and oxygen in the blood. So look at your key differences here. Your chemoreceptors in the medulla oblongata pick up hydrogen ions and carbon dioxide in cerebrospinal fluid, whereas chemoreceptors in the carotid and aortic bodies detect changes in hydrogen ions, carbon dioxide, and oxygen in the blood. I would highlight both of those sentences. Make sure you know which one does which. So if carbon dioxide and hydrogen ions increase in the blood or cerebrospinal fluid, the DRG is going to stimulate the VRG to increase rate and depth of breathing. So this will cause a loss of CO2 since we have an increase of carbon dioxide as well as hydrogen ions, which will lower the levels to homeostasis. So remember, the idea is that we breathe in oxygen, we breathe out carbon dioxide. So when we have too much carbon dioxide and too much hydrogen ions, we want to breathe quicker because we want to breathe out more carbon dioxide and hydrogen ions. If hydrogen ions and carbon dioxide have decreased in the blood or cerebrospinal fluid, we will have the opposite effect, so breathing will be shallow and slow. This will provide time for concentrations to increase back to homeostasis. So the idea is that we're trying to conserve carbon dioxide, but not breathe out as much. So the carotid and aortic bodies are also sensitive to a decline in oxygen concentration. So remember back a couple slides ago, the chemoreceptors in the medulla oblongata, or your central chemoreceptors, did not pick up any changes in oxygen. The only chemoreceptors that pick up the change in oxygen are located in your carotid and aortic bodies, which are also known as your peripheral chemoreceptors. So when they notice this decline in oxygen concentration, they're going to increase the sensitivity of chemoreceptors in the respiratory area to cause changes in the CO2 concentrations. So oxygen levels overall will have a very little effect on rate and depth of breathing unless they are very, very low. So they have to be very low in order to react, whereas we are more sensitive to changes in carbon dioxide concentrations. So now talking about the inflation reflex. So the inflation reflex, during this time we have our baroreceptors, which are our stretch receptors. These are found in the bronchi, the bronchioles, and the visceral pleurae. These are specifically sensitive to lung inflation or stretching. So inspiration will activate the baroreceptors. Then the baroreceptors will send action potentials via the vagus nerve, which is one of your cranial nerves, to the DRG. Action potentials will cause inspiration. These will then be inhibited. So action potentials causing inspiration are inhibited. And then it will promote expiration and prevent excessively deep inspirations. So we don't want too much stretching. And this video will illustrate that for you.
The Herring-Brewer reflex is initiated as the lung inflates. Stretch receptors in the lungs transmit signals to the dorsal respiratory group to terminate inspiration in much the same way that the pneumataxic center does. When the lungs become overly inflated, which is typically a tidal volume more than 1,500 cc's, the Herring-Brewer reflex acts as a feedback loop to end the cycle of inspiration. Also, like the pneumataxic center, the Herring-Brewer reflex can result in an increase in the respiratory rate.
All right, so now moving on to our irritant reflexes. So irritant receptors are sensitive to chemical and physical irritants in the respiratory tract. This can be things like smoke, dust, or mucus. When stimulated, they're going to send their action potentials again to the DRG. The DRG will alter VRG function in order to trigger a sneeze or a cough. Overall, the goal is to expel the irritants. Then we have our higher brain centers. So our higher brain centers, here we're going to have action potentials that are voluntarily generated by the cerebral cortex. So these are created when a person chooses to alter the pattern of resting breathing. So our voluntary control is limited. Overall, we have more involuntary control. So an example would be, if you've ever heard of kids that are trying to hold their breath in order to punish their parents, eventually that involuntary will kick in and take over. You can't hold your breath for that long. Involuntary action potentials from the cerebral cortex and hypothalamus, so that's where those will come from. These are created during emotional experiences that activate the autonomic division. Think about fight or flight, fear, anxiety, excitement. All of these are going to lead to an increase in breathing rate. Then we can have sudden emotional experiences, sharp pain, or a sudden cold stimulus that can cause apnea. Apnea means to stop breathing. So these experiences can literally take your breath away. And lastly, we have body temperature. So think about fever or times of exercise. So an increased temperature will increase your breathing rate, and a decreased temperature will decrease your breathing rate. And that's all we're going to talk about for today. Make sure to watch this video before you come back, and we'll pick right up with 14.7 when you get back from break. I'll see you then.